There you go. Now you have lunch.
Okay. Okay. So you want to make sure you record everything that happened. All right. You don't want somebody going home after a seizure, falling, come break their arm, and they come back and say they didn't protect me enough while that my son was having a seizure and he broke his arm due to the fault of the PTA. Right? You don't. All this stuff has to be documented before you leave. Okay. All right. So while we're going through this, you guys can use this as a guide. Okay. To look stuff up and make sure you know where some of the stuff that we're talking about is. Any questions on that? No? Do you think that's helpful? It goes through all your old books. You're welcome. All right. Okay. So you guys are going to help me go through the brain and CDA. Oh my God, what time is it? I gotta try to keep on time here. I don't know how that's gonna go.
Day 47.
Day 47?
It's 8:47.
Oh. Oh my God.
What time is it?
I know. My brain is going elsewhere. Stop making fun of me, Rebecca. Look at, see what I had to put up with 2 years ago? This is what I had to put up with 2 years ago. The dementia is kicking in, but. Huh? All right. So if we're in your book, is it on CDA? I know where it's at. Oh. Is 250? Is it 256? Where is it where it talks about the brain? Yeah, it's before that. Nope.
Um, 219.
Yep, 218 and 219. Yes. Okay. All right, so you pretty much have 4. Like I gave you a lot of this stuff here. All right. I mean, there's more than you probably need as far as the rows. But, oh, and that's upside down. Oh, well, that works. Okay. But you really only have 4 main arteries. Okay. All right. So you have, why don't you tell me what the 4 main arteries are? Anybody? Okay. Ugh. Anterior cerebral artery. Don't let these guys take over, guys, because they've been studying for a while. Okay, medial. Why do you think it's important to know where the arteries are? This side of the room. Which side of the brain? Well, aren't they on both sides of the brain anyways? But you have to know which side is blocked. Right. But what else is important about that? Where do these arteries go? Yep, to the lobes and to sections of the brain. What's the last one? Vertebral. Isn't there a loop too that's not in here? The basilar artery, yes. But then the whole, remember in the very middle section with the arteries, so you've got arteries here, here, here. Lupa, nope, that's down in your kidneys. But remember, there's that one section that goes around that can, if it gets blocked in certain areas, some of the blood flow can help out. Remember? Because there's still blood going in there. Remember this, guys?
Yeah, the cerebral, the brainstem.
No, brainstem is totally different. Can't remember the name of it. My brain. See, I told you. What the heck is the? It's very important. Oh my God, it helps. I remember in class I always used to say, but the blah 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 helps. If it's not blocked, it can supply a lot of stuff to it. Which artery? Well, let's go through this first. All right, so let's talk about the brain. What parts of the brain is supplied by each? Frontal. Correct. Frontal. Parietal. Oops, I thought I turned that off. What else? Temporal for medial. This side of the room is very quiet. They're not going to be there to take your test. Hello? Are you out there, guys?
No.
Why not? Come on. Am I overwhelming for you this morning?
What about the occipital?
Occipital. So isn't that the posterior?
Yes.
Yep. That's okay. Do you guys have Big Red?
Yeah.
Anybody bring Big Red? It'll show you exactly how the blood supply is in Big Red. Okay. Okay. So your anterior, all right, frontal lobes, okay, big one. Frontal lobes is going to be an absolute big one. Parietal lobe, that's going to be another big one, okay? And why? What in these are the functional deficits that you're going to see? So,
I joined the circle of Lewis.
thank you.
I just saw it too. Sounds right.
That's it. Yes, don't forget Willis. Because Willis helps. So what does the frontal lobe do? Right. Speech? Did you say speech? No. No. Mm-mm.
You have it in your paper.
Hmm?
You have it in your paper.
I have it in my paper
Yeah.
that it does speech. Which one? Which Wernicke's or Broca's? Broca's. Okay. So frontal is going to be speech, which is Broca's. Is that receptive or expressive? So what are you going to see with that? I mean, are they going to have a harder time understanding you, or are they going to have a harder time talking to you? Mm-hmm. And what are those called when there's issues with the speech? What's that word? Do not make me play hangman. Aphasia. Right? So there is a whole list of words that you need to know in here. I would make sure that you study those very, very well. Okay. A lot of your sensation stuff. Remember things like stereognosis, barognosis, deep pain, 2-point discrimination, vibration. You need to know all what those mean and how you would test for those. And then there is muscle movement terminology. Ataxia is coordinated movements, but what do we know which is specific? What part of the brain is specific to ataxia? Thank you. Cerebellum, which makes me say what artery goes ahead and gives blood supply to this cerebellum. Posterior, yes. Oh, I'm sorry. Why did I write posterior here? What was I supposed to write there? Occipital. Oh, God. I'm getting concerned for the next class coming up. Okay. So we know that with the cerebellum, right, it's ataxia, right? Ataxia is one of them. What's another thing with that? What else is in the cerebellum that's you're going to see? Balance. Thank you. So vestibular, right? Vestibular. Let's go back to the top again. No. All right. So we know that frontal lobe, okay, is going to be your primary motor cortex too, right? I didn't write that in there. So didn't you guys say higher order thinking, right? Isn't it cognitive? Cognitive. Order thoughts. Motor cortex. So if I have a right-sided CVA and it affects my motor cortex, what part of my body is going to be affected? No, don't stop that. You guys stop. Don't say anything. Huh? The left side. Yes. It's going to be the left side. Do you remember what? The opposite side. Do you remember why? There's a crossover in the spinal tract. Very good. Okay, so that's where those stupid spinal tracts come in that everybody hates so much. But I don't think that you need to memorize every single one of them, but we're going to go over the ones that are going to be important for you to memorize, okay? Because they'll be important not only in your incompletes, but also in your CVAs to understand that part of it, all right? So, all right, so if you look there, on page 219, okay, for the frontal lobe, we see that it does voluntary movement, which we just talked about, intellect, orientation. What are some of the orientation issues in a CVA?
Like speech, or like your balance. I meant like where you are in space.
Right, where you are in space, okay? And more, remember we talked about specific ones. Does anybody remember what some of the specific ones were?
Person, place,
No, that's not what I'm talking about.
You're talking about that chicken head thing.
Yes, the chicken head thing kind of stuff. Huh?
head writing.
No.
That's a reflex. That's a head writing reflex. Remember, we talked a little bit like left-right discrimination. We talked about somebody comes in and they see the world slanted, Remember those kind of things? They walk into a room. Okay. All right.
What's the word for it again though?
That was more like the left-sided, remember the left-sided neglect? They only saw the world as a half. Okay. But is that going to happen on both sides of the brain? No. It'll only happen if they have a right CVA. Okay. It's not going to happen if they have a left-sided CVA. Okay, so also Broca's, that's only going to happen if it's in the left side, if they have a stroke in the left side. Okay, it's not going to happen if we have a stroke in the right side. All right. So it says in here, it does say already in your book what you see as far as some of these functional deficits. Okay. Are we going to go ahead and work on Broca's aphasia? No. Who's going to do that? Speech. Okay. So if you see somebody that has Broca's aphasia, how is that going to affect your treatment? Communicating with them. Yeah. You're going to have to do a different level of communication with them. Okay. So they have a hard time expressing themselves, right? But there were ways that they went ahead and did that. And we talk about pictures. They had like pictures that they could point to express it. And that is the extreme. So not everybody can't say, they can't express themselves at all. But remember, there was that their words kind of got jumbled up a little bit. I showed you videos of that with the jumbling of the words, or do you think that you're going to give them several commands at the same time? Oh, no. Do you think you're going to give them long commands? No. How are your commands going to be and your instructions to your patients going to be? Short and simple. Okay. Not a lot of stuff going on in there. All right. So that's your treatment to improve, right? Okay. So short commands, picture boards, right? To communicate with them. All right. How about the cognitive portion of it? Are we going to improve their cognitive portion? No, we're not going to improve that either. But that's going to affect how we communicate with them and what they're going to be able to do. Okay. So do you think that they might be, depends on which side of the brain, right? All right. So if it is the right side of the brain, okay, are they going to be, are they going to be more impulsive? Yeah. Yeah, they're going to be more impulsive. Okay. So with the impulsivity, what is going to be a safety aspect of that?
Don't leave them alone.
Don't leave them alone. Yes. Impulsivity. Okay. So safety. Don't leave alone. Okay. You're going to get them up and they're in a chair. They're in a wheelchair.
Gate belt.
Gate belt. Thank you. Those of you that worked in rehab, did they have alarms on chairs? Okay. I read somewhere recently that they were saying that was too much of a restrictive device, alarms on. I'm like, how are you going to make these people safe?
So in the bed, when you put the alarm on the bed, they had to have one type of the railing down on the bed, or else they were blocked in too much. But a way to get around it is you could just drop the one by their head.
Okay. The one way up by their head, not the one on the side. Oh, that's
If you think they're going to get up.
Yeah.
Way around it.
That's interesting. Very interesting. See, so those regulations have changed since I did it because we didn't have to do that. If they had alarms on the bed, we had to make sure that all of the railings were up. Yeah, all of them. Okay, yeah, see, that's all changed. So that's why I wanted to ask you guys.
There, so hopefully the table was in their way.
Oh, yeah, so that they wouldn't, so it would be like a barrier for them. Okay. All right, so personality is going to be changed. So if they're a left-sided CVA, okay, we already talked about, we're going to see this on the right. What are you going to see on the left? Cautious. More fearful, right? So what do you think you're going to have to do with them? Much more encouragement. Okay. So this again is going to be a right. Okay, so you have to encourage your lefts. Do you think you're still have to be safe with them? Yeah, definitely. Yeah. They have right-sided weakness. Okay. So we also talked that they would have left-sided neglect. If they're a right, they have left-sided neglect, right? Correct? Okay. Okay. This is for a right CVA. God bless you. Okay. How is that going to affect your treatment? Yep. Yes. So you're going to stand on the right side. You're going to place things on the right side or left side. I'm sorry. What?
They have left side. Oh, if you want to train the left side, then
Yes. Okay. So you're going to stand on the left side. Well, you're going to stand on the left side anyways, because if they have left-sided neglect, that is the side that's going to be weak, correct? Okay. So you want to make sure that you're over there anyhow, safely guarding, correct? Okay. So you're going to stand on the left. You're going to place things on the left. What kind of exercises and stuff could you do?
Picking up cones from that side, removing things.
Yeah, picking up cones from the side. Yep, all that kind of stuff. What else?
Put a mirror in front of them.
Mirrors. Yes, very good. Do you see how, is this helping connect? Is it? Yeah. Okay, that's fine.
Yeah, I mean, I like the way that you're writing it out.
Okay. Okay, all right, and it's beneficial for you guys. Go ahead.
I have a question about, so we're still on frontal, right?
Mm-hmm.
And then parietal would be different.
Parietal will be different.
Okay.
Yes. Yeah, I haven't even gotten there yet. It's going to be a mess because there's not enough space. All right. Okay. Does that kind of give you an idea of things? I don't want to write a ton of stuff down. All right. And I'm not getting into the obvious. All right. So you have somebody who is a right-sided CVA. Motor-wise, what are you going to do? Motor. Where are you going to train? Left side. Thank you. That was such an obvious question. Yes. So you're going to work on their left-sided weakness. Okay. Contralateral weakness. Let's put it that way. Oh, that goes over here. And I think it's best if I just move everything out of my way that I could possibly trip over and hurt myself. All right. Okay, so they have left-sided weakness, and they have left-sided neglect. What are you going to do with this patient to start working on some of that motor control over there and also some strengthening stuff? Very beginning. Let's just start from the very beginning. You see them for the very first day. What are you going to do? They're in their wheelchair. You pick them up and what we're trying to, left-sided neglect, okay, and left-sided weakness. You help them, they're a max assist, and you help them to sit on the table, okay? So they're sitting on the table. How do you think they're going to be sitting on the table? Yep, they're going to be sitting on the table like this. So I can get off the table. Ugh, really feeling my age. Sitting on the table like this, right? Okay, so somebody come up and show me, what would you do to help me?
Amber's coming. Falling. Hurry up, she's falling.
Sure.
Maybe I would use like a bolster because pillows aren't going to be enough to kind of hold you up.
Okay. That's a good idea to help hold me up. But now you want to help increase strength in that arm.
Reach over there.
Okay. So I had you put the pillows on my right, and so that was my mistake because I had left-sided weakness, so I should have been this way, but that was correct. Okay, so I would reach over here, right?
And then you can go down on your elbow.
Okay, so this is here. She's got me set up like this. I'm not laying down. You want to work on strengthening this arm. Is this really strengthening this arm? No. So what would you do to strengthen this arm? So, I don't know what I'm doing.
Bend your elbow. Not sorry.
You know I have to slap you. That wasn't fair.
Why can't I just sit with you right here?
What else would you do to me?
Fix your head.
Or you could do perturbations. Yep, fix my head. How are you going to fix my head?
Send you to a different doctor. I'm a mirror.
Have a
What
mirror.
about the mirror?
Okay.
Look at Amber. You see Amber in the mirror? Look next to you. Close. And you can do.
This looks familiar, doesn't it?
Give her your finger.
I give her my finger?
Yeah.
I'm gonna let go of her arm right now?
No, use that hand. Don't point at them. Just hold it up. And say, follow my finger. Follow my finger.
Hi. But that makes sense, right? Okay. No, keep a hold of that.
Okay.
So I keep it. She's stabilizing my arm for me. But what else could she be doing to make me put more weight on that arm? Because I'm probably putting more. Yeah.
Forward a little bit, or not forward. This way towards me.
But where would be a better?
Elbow.
If she's got my elbow, where would be better for her to do? Up at my shoulders, probably, right? You want to get my trunk to move over to this direction. Correct? Yeah. So she would probably stabilize me here. So thank you. And have me move over there. Now I feel very secure.
I'm in your armpit?
No. But actually I feel more secure because she's trapping me at the joint, right? So you're going to have questions like that. That's how you're going to get her started, all right? What else in this position do you need to work on? Posture.
Trunk.
Yes, trunk. So what could she do? She's stabilizing my arm. Okay, what could she do? All right, like what?
Pull your belly button to your back.
Okay.
Oh yeah, round your, pull your shoulders back.
Where else could you place that hand? Yep. So she's got my shoulders back, which does make me go up. Yep.
Not on your microphone.
Okay. And if she's gonna do some other exercises, what other exercises might be helpful to make sure that she continues to use this arm? And she's got the mirror, so now she's a little bit better idea that that's over there. What else could you do? Lateral weight shifts, and then beyond that, lateral weight shifts would be a good place to start. Beyond that,
think it's pretty.
You're trying to work on my left side and
Reaching in
neglect.
different
Yes. So now I'm going to go grab Jackie's phone.
Oh.
Okay. So it requires me to put pressure on this side, right? She's assisting to make sure I don't collapse, but then I'm going over to this side as well. Okay? Makes sense? All right. So you can start off with weight shifts. You can start off just by fixing posture, making sure that they have this here, making awareness with the mirror. That would be initially how you start your program, wouldn't it? Okay. Then the next thing would be to do the weight shifts. Okay. So that they put more weight on that left side. All right. And become more aware of it. Then the next thing would be to actually have to take the right hand off and reach. Make sense? All coming back to you now? Thank you. Thank you. Except you almost dropped me. But, thank you. Okay. Does that all make sense? Okay. Because you're going to have questions like that, right, guys? Right, guys, on the test. Are you questions like that on the test? Okay, about what would you do if you saw somebody with left-sided neglect? You have a patient with left-sided neglect. And actually, I have a case study we're going to go over today, okay, that deals with CVA. All right? Okay. So let's get off of frontal. I think we've done enough with that at this point. Let's get on to parietal. All right, what does the parietal lobe deal with? Isn't that more with the frontal lobe? Comprehension of what, though? You're right. Comprehension, but of what? Yes. Yes. Sensation, right? What cortex is in the parietal lobe? What cortex is in the parietal lobe? So that's really important. This has got your primary motor cortex. Who's your primary motor cortex's most important buddy in the whole wide world? Nope. Thalamus. Stuff goes through the thalamus to get up to this section in your brain because the thalamus is the gatekeeper, sensory gatekeeper, right? Okay. All right. So parietal, what's in there? You have your primary motor cortex. You have afferent and efferent nerves, right? Efferent nerves are what? Are they motor or sensory? Sensory. And they go up to where in the brain, in the parietal lobe? What's that section called? I will tell you it starts with primary and it ends with cortex. Nope. Sensory. The primary sensory cortex. Remember? Remember, guys? This was only like almost a year ago. Seriously, you can't remember this stuff? And they have to go together. If you didn't have any senses coming in, what would happen to your motor responses? If you never got the idea that you touched a hot stove,
They would stay there.
you stay there and you burn yourself because your motor cortex would not have any input from the sensory cortex and you would have no reaction, okay? Or you might overreact if it's overreactive, all right, if something was completely upturned in there. All right, so as you can see, it's touch, it's kinesthesia, vibration, temperature, all right? You're, like we said, sensory you're dealing with, memory, okay, hearing, vision. So meaning of objects, why would meaning of objects, isn't that sensory? It's your sensory area. That's what the parietal is. It's really all sensory, okay? You do have some language stuff going on in there as well, okay? And it interprets words there and spatial and visual relationships. So I think if you look here, where is it? The parietal was, I thought Wernicke's was in there. No, Wernicke's is in your temporal lobe. Okay. All right. So it's sensory, 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 sensory. So when you think of anything between the two of these, frontal is going to be a lot of some of the speech, your cognitive stuff, and your motor stuff, and your emotions, and how you're going to handle some of those things. And then your parietal is definitely going to be your sensory. All right. So I showed you that video a long time ago, okay, where the guy goes in and he touches, he's walking through the woods. Remember the guy's walking through the woods? He's going to take a bath in the pond. And he gets scratched on his leg, and his past experience has told him that he just got scratched in the leg. Remember this? Okay, and it was, yeah. So he's thinking, oh, it's a scratch in the leg, goes in, takes his bath, all that other kind of stuff, comes out and practically drops dead because he was bitten by it was the second poisonous, it was thought to be the first, but now it's the second most poisonous snake. All right. So, but then the next time he walks through the woods, then his perception of that all changed. All right. So now when it goes through the thalamus up into his sensory portion, the thalamus goes up and says, hey, sensory cortex, we just got hit by something here. Okay. Scratch. It feels like a scratch on the leg. Like, what do you want me to do? Like, should we yank our leg back? Should we run for help? What should we do? And the sensory cortex says, oh, nah, that's just a scratch from a tree. You're okay. So that's the first time. All right. Because it interprets it. Second time, walk through the woods, feels a scratch on his leg. The thalamus goes, oh my God, we just got it again. What do you want me to do? What do you want me to do? This could be a problem. And the sensory motor cortex says, oh my God, call 911 because we just got bit by a snake. Because that's what happened the last time. But remember, this time he just got hit. So he just scratched his leg. Okay. So you see how those work together? All right. Questions? Problems on those? What time is it? 23. I have 7 minutes. So in temporal lobe, what do we got in temporal lobe? Where is the temporal lobe? Yes. So if you have your temporal lobe over here, what do you get? Audio. Yes, hearing. That's a biggie, right? Wernicke's.
I always forget the difference between Wernicke's and broken.
Okay. So good. I like that. And Wernicke's is what you're hearing, so you don't understand it. Yeah, receptive aphasia. So this is expressive aphasia. Okay, Wernicke's is receptive aphasia. Okay. So this is, like she said, broken speech. Ugh, don't take a picture of that because it's horrible. And Wernicke's is, so it's they're not like
Not hearing
they're it's like you're and the yeah.
Cutting out.
Yeah. So, but they don't understand it. That's not what they hear. But it's like if you're going with your cell phone and you get to an area where you start to cut out and you hear every other word, like you're not going to totally understand what they're saying, right? You're going to make somebody repeat it. Right. But that ends up being more the expressive part of it, right? Yes. So sometimes
they don't understand what you're saying, and then what they're expressing also doesn't make sense because they don't understand what you're trying to say to them.
Well, no. So I knew a lady that she did not have any problem understanding what we were saying to her. She understood it completely, but you can't really tell whether she did or not because what she's communicating back.
So I thought that was the case, but then you had just said they don't always understand what like they're receiving because it's receptive. So then
I thought hearing too. Yeah.
Okay. All right. So,
I'm like, because which one are you talking about? Because you said Warren
yes.
and then
Okay. Wernicke's is they're not understanding what they're receiving. Okay. Yes, because it's receptive. All right. So what's they're receiving in is receptive in
And then they can
Wernicke's.
talk fine.
they talk like it doesn't make sense.
It does, yeah, because not because of the expressive aphasia, but because they not understanding what you're saying. So if you understood 100% what somebody's saying, you could come back with a very literal and literate response, right? But if you don't really understand what somebody's saying, like I talk to my husband and I laugh half the time because he's 80% deaf in one ear. Yeah. Yeah. Well, actually it can be an advantage at time. Like when I get really mad at him, I always check to make sure I'm on the left because I can like mutter under my breath and he doesn't hear me. So don't, Andrew met my husband, so don't go ahead and tell him that. It's my own little thing. Like I got really mad, I can do that. Don't you? That's right, you did. Don't he know? Actually, he does know that I do that. But he will go, yeah. But sometimes, like I will say something, and his response back to me is just like, "Huh? Like I have no idea what you just said." And it was because he did not hear it very well. Okay. Yeah, half the time he doesn't want to. But these people, they could hear it, but they don't understand it. They may have, it's auditory too. So they may have an issue hearing it as well. All right. So a lot of times people that can't hear well, they think that some people that are treating them or working with them, they think they have dementia and they don't. You have to tease that out. Like they don't really have dementia. They just could not hear well. So they're not understanding what you're saying, which is receptive. They assume what you're saying. Yeah.
But if you know the birth is aphasia, then you'll know what the other one
Yes.
is, what the opposing one is.
Exactly.
And you just know that global is like everybody in the globe.
Yes.
Both of them together.
Yes. So that's the way I remember it too. So Broca's is broken speech. Okay. So you're trying to express and it's not coming out correctly. Okay. Wernicke's is the opposite of that. Okay. You have to be able to hear and understand in order to correctly respond. All right. And then global, I think it's just global. That's how I always remembered it too. It's both. So global, a lot, you see like a flat effect because they're really not receiving or expressing at all. It's like nothing. There's nothing there. Like the light's on, but nobody's home. Okay. It is sad. That is pretty sad. Okay. Occipital lobes. Vision. Yes. Distance judging. So anything that deals with vision, light, shapes, any of that kind of stuff. Okay. What does the vertebral artery? What does the vertebral artery go ahead and? Where is the vertebral artery? The cerebellum. Also. We already talked about what the cerebellum does. And what else? Does it hit into the brainstem?
Yes.
And if it hits, what does the brainstem do? Yep. Monitors all your vitals. It's your vital area. Monitor vitals. So I always think brainstem is vitals. So if you have a major stroke in your brainstem, yeah, bye-bye. Remember we talked about discerebit and decorticate rigidity? Mm-hmm. Okay. So you could end up seeing some of that. I don't think I'm doing this, spelling this correctly. Yeah. And make sure you know the difference between those two. And which one's the worst? Though I don't think you're going to end up seeing that in the test. The one with the more ease. Yeah. I always think this cerebit kind of reminds me of cerebellum. And if my whole cerebellum was injured, I'd pretty much be brain dead, right? Okay. Well, decorticate is the opposite one. Yeah. So this one's the flexion one, decorticate, right? And this one's the extension one. Yep. So extension. I always think cerebellum. Bad. And then extension. And you got all those E's in there. Okay. Are we going to treat that? Are we going to resolve it? No. Okay. But can we be involved in it?
Yeah.
How?
More teaching.
More teaching caregivers? Correct. What'd you say? Yes. Caregivers. So pressure relief, which would also involve positioning, right? And what else can we do? Passive range of motion. Okay. And they have what? What's something that you always see as far as just with an upper motor neuron lesion? Yep, rigidity, which right before that would be spasticity. Yes. Yes. So remember those. Upper motor neuron lesions are always spasticity. Lower motor neuron lesions are always flaccidity. And remember the stages of motor return. So they start off flaccid. Remember that? There's no voluntary movement whatsoever. Okay. Then the spasticity starts to develop. All right. And you can start to get a little bit of not so much voluntary movements, but where you're starting to be able to move different segments a little bit. Okay. A little bit of voluntary movements. Then you get up to, remember the chart? Okay. So you had your chart that was, one went up, it went up like this, right? And then it went down like that. Which one is that? Right. This is your spasticity. And then the other one went like this. Right? And wasn't that your motor return? Right? I know, I'm in front of you. Motor return. So remember we talked there's different stages. So this is obviously 1. Okay. This is obviously 2. That's 3. So to me, this is the most important one to remember. If I don't remember these, okay, and then there was like 4 and 5. If I don't remember these, why do I want to make sure that I remember this one? It is the turning point. It is the point. So I can't remember everything, obviously, but this is the turning point. So if I can remember that this is where motor return is starting to exceed over spasticity, I know that by stages 4, and this is complete motor control, okay? So this is much better, and then spasticity starts to go down, all right, by the time you hit 4. And this is flaccidity, okay? I just remember that if I go backwards, this is going to be a little motor return, more spasticity. This is going to be flaccidity back here in 1. This is going to be complete. Do you see what I'm saying? So if you remember this, you can figure out the rest.
That was in our small neuro one, right? Or big red?
Yeah, for the spasticity.
I think that was in big red, I thought. Yeah, I'm pretty sure it was in big red. Okay. Makes sense? Okay. So that's how I always try to remember those kind of things. All right. Okay, last one, because I'm over and you guys are going to take a break. Okay, so precautions, contraindications. Precautions, what precautions are you going to take? We already talked about some safety ones if they're impulsive. What are you going to do every time you see this patient? They just, be alarmed?
Turn the alarm on.
Turn the, no, nope. Nope. It doesn't matter. In general, with any stroke patient. Orientation would be a good one to see where they are that day, especially if you've never seen them before, right? Okay, you want to get up and walk them. You're going to try to get up and walk them. Vitals, thank you very much. You're always going to take their vitals. Okay? They've been laying in bed for a while. What do you have to worry about? Pressure ulcers. Thank you. Yeah, pressure ulcers because they've been laying there. I will tell you something. First of all, if you ever get into a situation as injured as I was, it's really scary because you know about all these secondary complications and it's really freaking frightening. If you can't move or they're not allowing you to get out of bed or move or roll or do any of this stuff, I swear to God, I thought I was getting a sacral ulcer. Like I wasn't, but I thought I was, I did start to, what's another thing if they're laying flat too much? Blood clots. What else? I was worried about that too, by the way. You don't know how much time I spent doing ankle pumps. 4 days.
Oh my gosh.
Yeah, because they bumped my surgery. Like they canceled my surgery on the day I was supposed to have it happen. Oh yeah, I was pissed. If I ended up with any of those secondary complications, I was going to sue. I was mad. I was really irritated, especially when they took the lady with the wrist fracture before me.
She was fine.
She was fine. She would have been fine. Especially when she said, "Oh, can I use the restroom first?" I wanted to say, yeah, wouldn't that be nice? What else? What other system? Pneumonia. Yes. So you want to look for, they may not go into pneumonia, but you want to make sure that we don't have issues with respiratory complications, right? Which, by the way, I had to ask for my own incentive spirometer.
Terrible.
Yeah. Don't go to Ocala Regional ever. I was forced there. Don't go there. Don't tell anybody I said that either. Oh my God, I just recorded that. Oh God. So, yeah, blood clots. What else cardio-wise do you have to worry about? You're getting them out of bed. You sit them on the edge of the bed.
Andrew already said it, orthostatic.
Oh, I missed that one. Thank you. Orthostatic hypotension, right? And then what else are these people at a risk for? Big risk. They just had a stroke. Another stroke. But I will say that contractures, okay, it would be something that you would want to make sure that you treat so they don't get them, right? Okay, so that's why I would start doing like passive, if you can't get them up and walk, if you can't get them to do a lot of the voluntary stuff, and the spasticity is starting to set in, which sets in pretty quickly, okay? You want to be able to prevent those contractures, right, Caitlin? So good thing, prevent contractures. Help? Okay. Any questions? No. There's a lot. And I know I went through this, but I already went over. Why don't we take like a 10-minute break? Okay. Does anybody know how to pause this? Shut it off and then turn it back on. Yeah, I'm going to cut that part out. I can't see.
Might be on the computer.
Oh,
You know what I'm going to ask? There's got to be a way to stop. I'll go ask. So 10-minute break, guys. Come on back at 10 of. I'm already behind. No. Can we pause that? Do you know how to pause it?
He doesn't want me to pause it during breaks.
Oh, he doesn't. Okay. Okay, that's that's fine.
Yes, I do, but he doesn't want me to pause it during breaks.
Okay.
Only at lunch. That was
Oh, I'm sorry. Yeah. Okay. Yeah. Okie dokie.
So if you have to go to the bathroom, I would say turn it off and take it off if you don't want to go to the bathroom.
Yeah, I'm gonna take it off because I don't know how to.
That?
Do you know how to show?
Yes.
It's down. It's in the back or the front?